just one or two contributions I would want to people to make comments on that. Anyone, please? Anyone wants to make a comment?
Good evening, sir.
Good evening, sir.
Ogulino from Ikiti.
Good evening. Please go ahead.
Yeah, outcome measures are standardized assessment tools that are either sensitive to particular conditions or risk factors, and that can be reproducible. Thank you, sir.
Okay. Now, my question, don't go yet, bros. My question is, why must we bother about it? Why must we bother to use an outcome measure?
Okay, sir. First, like I said, it's a standardized measure. Then, secondly, it determines the interventions, appropriate interventions that might follow. That's my opinion, anyway, sir. Thank you, sir.
Right.
Good day, sir.
Good evening. Now, okay. Let me listen to somebody else. But bros, you have not answered the question.
Okay,
Good evening, sir.
What you did is to define outcome measure, but I'm not asking for the definition. That why must you bother about it? Okay. Good evening. Good evening, please. Nafisa, go ahead. Yeah, Nafisa,
I
go
think
ahead.
it can be used to determine the effectiveness of our intervention, how effective it is.
How effective our intervention is. Right. So we bother about it because we want to know whether the intervention we are using benefits the patient or not. It's effective or not. So
yes,
bother about use of outcome measure. Okay. So let's go ahead now and look at it from broader perspective. We will still come back to the same question, so we don't spend a lot of our time in that. So I will try as much as I can, because this is a presentation that I have to share a slide. So I decided to put some information there, but left to me, the slide that I prepared actually before this evening is just 7 slides. And I felt maybe that would be too small, because I felt there is no need for me to go over definitions of. We are very good as Nigerians in cramming definitions, in cramming books and all that. Sometimes what we cram, the challenge we have is about how to implement them, or why must we even use them when in our clinic we are so busy to the point that all what we are saying sometimes just become theoretical. But if we know why we must bother about it, then whatever we learn wouldn't be theoretical. But it will remain theoretical if we cannot actively link why must I bother about it, since I can treat my patient without using them and I'll still get paid. But why must I bother about it? And I think that is where the use of outcome measure becomes something for us to think critically as therapists. Again, in one of the questions I said professional, which is specialist. If we said we are specialists and we cannot, or we are not holding ourselves accountable to what we are doing, then if a management employs a physical therapy, a physical health exerciser, or exercise physiologist, let me put it that way, or a technician who is not well trained and who cannot measure outcome, since we ourselves cannot justify what we are doing, then it might be difficult for us to say we are truly a professional. That's one way of also looking at it, that we should bother, because when we measure and we are accountable, it makes us a better specialist. And it gives us the edge over anyone who might be doing our role or want to perform our role, but don't have any means of measuring the effectiveness of what they do. Online, we see a lot of people who are copycats, but what they cannot do is to provide evidence to justify what they do. So, advances in healthcare and improvement in quality of life is a major factor for why we must measure health outcomes. This improvement brought changes in policies all over the world. Patients now know their rights more. Again, the health system is constantly changing despite all the rivalry, which now meant every therapist have to justify their choosing interventions and measure outcomes. It is not enough for us to purchase equipment in our department, even when we don't have a population of patients that uses them. And I think I have said this in other lectures that I have had, that a department requires about 7 equipment. Each one of them costs millions because it is in the list of MRTB. However, looking at the volume of patients that comes to that department, only one of all this list of equipment is beneficial to their type of patient. And we asked our management to buy a total of equipment that will cost up to 15 to 20 million, even though those equipment wouldn't be beneficial. Then at that point, we are not acting professional. We just want to fill our department with tools that are not beneficial to the needs of those patients. But we'll talk about that. But we are talking about measuring health outcomes. And I think we also will come to the term, why are we calling measuring health outcomes? And is it the same thing as outcome measures? Because what I'm explaining at this point, I'm explaining measuring health outcomes, not the outcome measures. So we need in our practice to be able to separate the overall picture of measuring health outcomes and outcome measures. Just like my brother said earlier, he defined outcome measures, but he's not looking at it within the context of measuring health outcomes. But when you think in the context of measurement of health outcomes, then you will know why you bother or you don't bother about an outcome measure. Right? Again, an occupational therapist might use an outcome measure relevant to his practice. A P&O might use an outcome measure relevant to their practice. A physio, a speech therapist will use an outcome measure relevant to their practice. However, all of us, we are working within the same health system where these outcome measures, these different tools must have a basis where we all come together to look at effectiveness of our work as a team. In essence, we can have several outcome measures. We can have several outcome measures. And each one of us is looking at different aspects. How does it impact the health system and overall health system? This is where our challenge comes in, because Outcome measures are just tools. Measuring health outcomes look at how we impact the system, the health system, not just the tool. So what am I saying here? We are trained in Nigeria to look at the tool rather than the system. So we are not using the tools to investigate our system and how to make our system better. Rather, we use tools to just investigate a particular part of a patient and let it be. Maybe as we go along, we will be able to shed more light on this true aspect. For me, we need to move a lot more inside measuring health outcomes if we are going to be better in our practice. But like I said, we are, from our undergraduate years, master's, PhD, we focus so much on the tool rather than the system. So there is nothing feeding back into the system. We are not challenging ourselves. Because we are not challenging ourselves, it's the same reason why someone can use a lecture notes that he has developed 20 years ago, 25 years ago, and still be using it. It's the same reason why I can work in a system for 15 years and I can tell any of my juniors, that's what we have been doing. Don't bring any new idea into our system here. No, just do what I ask you to do because that is what we have been doing. It's because we are not evaluating where we are. So assessment and intervention may include identifying and recommending appropriate aids or devices on behalf of patients. Employers also need to get information. What is the evidence for what you are doing? A lot of us in our practice, we know what we do works. But when we face other professionals, let me say a medical doctor wants you to justify what you are doing. Some of us get angry because why would you be asking me the benefit of TENS machine? Is it his work? He has every right to ask you. We are all working in the same system. A lot of us uses tools, aids for interventions. A lot of us also use our gut to apply them, and we cannot objectively bring up rationale why we do what we do. And again, we don't provide information based on evidence to our employers why something should be done. We make recommendations based on what we think we want, not based on what evidence says. Maybe, for instance, at last week, I can say Amdala here. Good afternoon, my dear. I mean, I say good evening, my dear. Afternoon. Like we want an equipment at last week. Do we recommend or request equipment from management based on the population needs or based on what the MRTB list says? Again, insurance wants to pay for measurable outcomes. A lot of us, because we work with government and we don't deal directly with insurance, we don't know the impact of employers and insurance. But I can tell you, I've had patients from Central Bank of Nigeria. The HMO wants evidence that what I've done works. Otherwise, it will not pay. So whether I'm using plant therapy or whatever therapy, what they wanted is the evidence that it works. It means, where did I start? What did I start? What did I achieve? And within what period? So before they pay me again or they renew if there is need for further treatment, I must provide evidence of where I start and where I get to before payment is made. But in government hospital, whether the patient improves or not, it's Tinubu that we are treating. not the patient. Because a lot of us in government hospitals, we are not really accountable. So in order to do this, we refer to evidence-based practice. Usually we get our evidence in the form of published materials, literatures, journals, newsletters, books, and all that. But again, while we are not going into real evidence here, we must understand that the information we use is quite important. And where we get this information is also important. Do we get information on YouTube? Or we get information from Google Scholar? Wherever we get our information, we need to evaluate it. We need to appraise our information so that we know we are using the best information and we are using it appropriately. Not everything on YouTube is valid, and not every information, even in a book, is valid within your context. Again, not every information you find on Google Scholar, not every article you see on Google Scholar is worth it. There are a lot of journals on Google Scholar that will not make it into Cochrane, for example, will not make it to PEDI, but they are there on Google. So it doesn't mean that all the evidence you see on Google Scholar, that all of them are valid. Anybody can put information on Google. So where this source of information is limited or inconclusive, when we are investigating a particular case, we refer to examples of best clinical practice, which may occasionally be the opinions of experts in the field. It is this best clinical practice now that forms the highest border, the height of the pyramid of evidence-based practice. In years past, it's not so. Everything is assumed to be, yeah, this is what I found from literature and this is golden. But best of clinical practice now form clinical practice guidelines that now form the top border of evidence-based practice. But then we are going to have problem again in the context of our country. Because our practice isn't standardized, it's difficult to get best of evidence clinical practice. Sometimes how we define the same problem is different. For instance, maybe I see a patient and I call it diplegia. I go to another hospital, I saw the same type of patient and they call the same patient alternating hemiplegia. How do we get evidence that we are doing the same thing? I have seen patients where therapists describe scissors gait. And what I saw there isn't a scissors gait. But that is the way they were taught on gait pattern. And he said, no. Whoever taught this as scissors gait maybe needs to come and see cerebral palsy and see through scissors gait. So if we cannot come together with this, it's difficult for us as professionals to operate and use the best of clinical practice. I'm trying not to make this too academic, but I've asked about 4 questions that are going to be challenging for us. That's why I'm going through this. Like I said, I just wanted to present 7 slides. So if you see me jumping some, please tolerate it. So sometimes evidence gathered from perspectives and experience of groups of people in the same profession doing the same thing to get a consensus can also be grouped together inside our DFE study, which we can bring up, right, to form best of clinical practice. However, like I said, if as professionals, we cannot agree on the same consensus, to describe group of conditions, then it is difficult to even say we want to do Delphi study in Nigeria. But they are very important in evidence-based practice now, especially when clinical practice guideline forms the top of evidence-based. So I'll just rush through this. I'm not going to go into definition. We all know definitions. So measuring health outcome, we use measurement tools, which are outcome measures, basically, instrument, questionnaire, rating, and all that. Like I said, an OCL works under measuring health outcomes. Measuring health outcomes look at overall context of the health system and how it works together, providing evidence to feed the overall system. While outcome measures talk about just the tool that you have used, which is where we are focused on. And let me say it clear, as long as in our practice, we focus on the tool, not on the system, we cannot improve the system because we are not relating the tool we are using to how we can better the system. We just want to measure outcome of a stroke. However, the system where we are managing the stroke patient, is it conducive for good recovery? Is it conducive for good rehabilitation? Will the patient get the right effective treatment based on what we have on ground here? What are the perceptions of patients that have stroke that comes into this place regarding our progress? Those that have come last year and those that are coming now, is there a change in their perspective of our service? Is there a change in what we do? Oh, they already know what they have done last year. They have to repeat it this year. They don't see any change to the point that many of them felt, what am I even going to that hospital to do? Since, it has become monotonous, actually. So it's like reading a verse and you repeat the verse over and over and over and over and over again. Yes, you have memorized the verse without actually reflecting on, do I have a new perspective of that verse? What do I mean? I'm using an outcome measure. Let me relate it back into a social system. I pick a verse in the Bible or in the Quran, and I've read it so much to the point that, yes, I know it offhand, right? Okay. I pick this verse and I understand it. Now, when I traveled, I interact with people, reflect on what I have learned, that verse have a different meaning to me because I have grown. So the same verse that I've read after some years, after gaining experience, gaining wisdom, interacting more, I gain further perspective. And I go back to that verse again and I realize it has a deeper meaning than what I used to interpret it, which helps me to go better. Now, look at that outcome measure, that tool. You use it within this context. Have you ever thought that this tool, what is it providing me politically? What is it providing me economically? What is it providing me socially? Rather than it's just telling me the range of motion in the knee. Can I look at that range of motion in the knee that these patients have? How many of them have it? Does our stairs have allow them to be able to make effective use of that range of motion? What is their environment like? What is our locality like? What can we change? Can we talk about how the level of coverage should be, can we talk about the environment, how it can be structured in such a way that a lot of this kind of patient can have access, and we can come up with an average of what should be done, which fits into the system. In that case, we are looking at the OCN. Now we can look at it from political perspective. We can look at it from economic perspective. We can look at it. So the same information that I've used this tool, I can turn it into a political tool, in essence. But I can only do that when I'm looking at that tool from measuring health outcomes, not the tool itself as a tool. Like I said, I'm going to shake up foundation, but please take it like that. I'm trying to rush. So properties, yeah. Again, I'm not going to go into all these details. We all know all this. We, from our undergraduate years, we cram it and all that. So just for Rose, because I don't want to even talk about all this, I just put it there. Because I know if I ask question, a lot of people will say this off head. So a certain intervention in measuring change, basis for generation of evidence, standardized, reliability, sensitivity, validity. We know all this. However, how has it impacted our practice? Because we have taken it as a tool. So I'm not going to go over that. So we need standardized outcome measures. Measure status, providing a baseline to monitor change, provide feedback to clients, communicate with colleagues, to evaluate our intervention, practice competence and proficiency for research purpose. We can also use the outcome measure for professional accountability and to justify the cost of treatment. Again, now we are using this outcome, this tool, within a different context when we are looking at accountability and to justify costs. Okay, I use a tool to measure range of motion. I'm just making it right. Okay, my goniometer, which is the simplest of two. Can I use goniometer to justify costs of my intervention? Like, how long does it take me to move from a range of 30 degrees to a range of 60 in the knee? What effort did I put in? Can I justify the cost from 30 to 60? Not just for the change, but rather I'm putting in cost now for my time, my effectiveness, my proficiency. Can I do this within 1 day, or do I do it within 1 week, 2 weeks? Am I justifying the cost of my time using this same tool? Now, I'm applying this same tool within the context of economic now. Not just within the context of, I'm using a tool to measure my shakaku. I pull, drag, strength, far, pull, strength, gain, muscle power, 4, 5, 10. Stride length, cadence. I've measured it. Economically, what is it telling me? Politically, what is it telling me? You can only do that when you move inside measuring health outcomes, because you are now looking at overall picture, not just the two. We are managing human beings who are social. We focus a lot in our training from our undergraduate years to the end of our career on the tool, not on the person. We can use the same tool to guide health policy. Do we use it within the context of health policy? Do we measure to look at how can this change our rules and regulations? That is what measuring health outcomes we talk about, not just the tool. Then to maintain quality. So if you see me jumping some slide, please just pardon me. because I did not even intend to talk this long. I'm going to skip these. So clinical governance. These tools are very important for clinical governance, which provide a framework for us to have quality assurance. Clinical governance studies provides evidence that service users benefit from continuum endeavors for improvement. So we must continue to improve ourselves. We must continue to improve the system. We must measure for the sake of providing overall context of what we are doing and how things can continue to be better, rather than this is what I have been doing. And I expect Chidera is working with me now. Chidera must do exactly what I have been doing since 19 Odogboboro. That's where our forefathers started. So we are going to pass it down and all that, even when the context and circumstances have changed. So an outcome measure is a very important tool for us to be able to develop clinical governance, because the outcome measure provides a baseline where we can all pool our resources together to guide our current practice. If you can get a baseline of consensus based on agreement, that baseline allows us to compare over time with other interventions and with other services. If we can find a baseline, then we will be able to compare and pool resources from BUK to UCH to Unilorin, to University of Ife, to LASU, because we have a baseline and we can pool resources. As long as there is no baseline, it's difficult for us to get to that peak of evidence-based practice, which is clinical governance or clinical practice guideline. So what are the areas of where we must improve in our clinical governance when we are using measuring health outcomes? It helps us to reduce inequality and variation in our services towards the same disorders. Inequality within our own center. When we have a baseline, a benchmark, Dr. Adelibibe will not see a patient one day and Chidera sees the same patient and she's doing a totally different thing from what Dr. Adelibibe is doing. That is inequity already within the same system. So if patient comes one day, sees a therapist who does one thing and another time is doing something else, there is no consistency. Sometimes it's better, sometimes it's worse. And sometimes the patient regrets even coming to the clinic at all. The involvement of individuals, outcome measure will help us to know how much we engage with our patient, with our clients, because we are going to bring in their opinion. Then we will also be able to share good practice, what has worked, why it works. We will be able to use good use of information, detecting and dealing with poor performance. I just put in this UK context because I wanted to use it to have an extensive explanation of why this applies to us in this context, but I'm going to skip it. Now, international perspective, let me pick this aspect because it relates with measuring health outcomes. Like I said, we don't do in Nigeria. If you are practicing in a place like UK, you must quickly understand that measuring health outcomes is very, very important. Because in my experience, I work hard a lot. And I can say that I'm a workaholic. But while working outside, I realize hard work doesn't necessarily make you better and productive. But working in a way that it is consensual, and like, I'm trying to use a very simple word. It's not about, yeah, you are efficient in your practice, right? You are productive, but you can be productive without actually putting yourself in that I'm hardworking. Everybody see me all over the place. You can be seen all over the place and yet not productive. Again, we do a lot in Nigeria. I was in a place where they are talking about poor people and wealthy people, and they are saying we are lazy. And I remember former president, may God rest his soul in perfect peace, Muhammad Buhari, when he said Nigerians are lazy, a lot of people condemn him. But the reality is that there are a lot of people who work in government service. You will see them moving around, you will see them talking, but the file on their table is not moving. I went to a supermarket to get something, and the cashier spends so much time joking with almost everyone that I have to call her attention. Attend to me. I know everybody here is your friend, but you have spent 15 minutes joking and chatting with everyone, not even attending to the web. So we customers are piling in front of her on queue, but a lot of times she's just spending it joking and playing. I don't think that is productive, but she's hardworking. Everybody like her because she's joking with everyone, even though the queue is not moving. So outcome measures, why bother? I'm now answering Ayodele's question now. We use the outcome measure for practice contests, our home practice contests, to improve our practice. We use the outcome measure for political contests. If we use an outcome measure to measure stroke and all that, and we see some pattern in the stroke, we can write to the management on how we want to change stroke management, because based on the evidence we are seeing, based on facts. That point, we have turned into a political contest of the measurement. Not just the range of motion, not just the gait pattern, not just the spasticity, but rather we are now using it on how overall management between us and the medical doctors and all that, or the OT or the P&O, how we can improve better. Now we have pulled our findings into political context to change patterns, not just for the patient, but overall system of how we work. So we can use this same outcome measure where we are looking beyond the truth, but we are looking at the system. So we can use the same outcome measure, even though we are using it for political context, now for economic context. Because we do this ABCD, we would like to review the price of this and make it better, or we want funding for this aspect. Now that is economic context. Can we get to fund this aspect? That is economic context of our measurement. Then we have political context of policy and our practice. Because we know we are living in a system and we are working in a system where the medical doctors has his own idea. P&O has his own idea. Nurses have their own idea. There is always a contextual issue of policy and practice. More so, we are not in charge of the policy. We are in charge of consuming the policy. Then we must know how to play use of tools to influence the policy. If we don't influence the policy based on facts, we will continue to challenge medical doctors that they are not carrying us along. Even if they carry us along, without good evidence, we can't change the policy. Then for quality assurance. Why is this important? Again, let me re-emphasize. If I use goniometer and I want to communicate evidence from my goniometer to physiotherapists, I know how I'm going to present it within practice context. If I go to the CMD and I present the same information the way I present it to my colleagues in rehabilitation, it will be meaningless because I'm not being professional. The CMD is not interested and will not be interested in your measure of spasticity. How does it impact the volume of patients that we see in our hospital? Look at it from a global perspective. Now, if I want to submit a proposal to State House of Assembly, and I write out information of this outcome measure the way I present it to my professional colleague, do you think the Minister of Health, the people in the House of Assembly will be listening to your terminology of 10 degree, 20 degree, 30 degree? You think they are going to be interested in that? They will be interested on how many people will be impacted by this information in the village, in the rural areas where they will get votes. Then you must interpret that 30 degree, that 20 degree, that 60 degree within the context of what benefits it will bring to the population. That is measuring health outcomes. So the same information, I can use it. The way I will present it to the CMD is not the way I will present to a politician. If I wanted grants, it's not the same way I present it to my professional colleague. I will go and present it to people who give me funding. In the same way, it's not the way I present to those who give me funding, it's the same way I'll go and present to the National Assembly. Many of them will be dozing by the time you start your terminology. You don't need it. They want what will be the impact. How many people will benefit from it? Then what will be the cost of budget? And okay, if they can bring the money, what will it impact in my constituency? What can I take to my people? That's what they will be thinking. Not what you have measured, not those percentages, not those degrees. That is the only way we can use outcome measures to benefit our practice and change our practice for the long term. As long as we stay with the truth, the way we are taught, we will continue to graduate more and more therapists and all that all over the country. The system will remain exactly the way it is because we are concerned about the truth, not the people. So I'm going to jump again. I don't want to, everybody, there's no one here that doesn't, people give me lectures on all this and I would love to listen. I'm just fortunate to be here. I mean, to come and open my mouth and say something, even though I'm terribly hungry. So evaluating interventions. Why we use the outcome measure? Every intervention also can be appraised. Why do I use it? In what context do I use it? And how do I apply it? In what context does it work? So what I mean basically is that we must appraise every intervention based on the theoretical basis before using it. We must do critical appraisal. We must understand the depth. And what is depth? Depth is clinical reasoning and critical thinking. I know a lot of time we get lectures on clinical reasoning. Again, this is a problem because we extract clinical reasoning out of depth. But clinical reasoning is just one aspect of your depth of understanding of the problem, the situation, even the disease. So when we synthesize clinical reasoning out of depth, We just want to teach how people should reason without teaching the depths of their reasoning. Again, we do this a lot. Then your competency to apply it. Do I have enough knowledge to apply this? Do I have enough knowledge to appraise it? And I'm on the contextual factors. Again, a lot of us were eclectic practitioners. That is, in our practice, we combine different interventions. Very few Nigerians really use a single intervention. Maybe you are treating a stroke patient, for example. That stroke patient comes into the department, you do your math exercises for the patient. That PMPNF you have done is an approach. After that, you tell the patient to carry weights, muscle strengthening. Muscle strengthening is an approach with its own theoretical basis, with its own evidence. That's true. Then you put the patient under infrared lamp. Infrared lamp has its own mechanism of what you want to trigger in the patient, with its own physiologic mechanism. So you have PNN that you apply with its own physiologic mechanism. Muscle strengthening with its own physiologic mechanism. Infrared with its own physiologic mechanism. Then you cap it up, either it goes on treadmill or it does bicycle ergometer. Some of us put them on body blasters, multi-gym, all of them with different mechanisms. What have we done here? We have combined about 4 or 5 approaches, 4 or 5 interventions within the same patient, within one patient. So we are eclectic basically. The challenge we might have here is that sometimes within a single therapy session, we are using both restorative, rehabilitative, and compensatory at the same time. So it's like my engine did not start. So I want someone to come and help me push. So I call Joseph Olamide, I call Ayo to come and help me push. So they go to the back of my car, they were pushing. Then Dr. Rigbe came in front, Chidera came in front. They are pushing from the front, backward. While my guys are pushing from the back forward. Then I have some people who are holding the door open. And I don't know, or who are giving me a guide on how to turn the steering. So we use compensatory, restorative, rehabilitative at the same time. We take a pencil and a cleaner to write without critical appraisal, depth, and we practice eclectic, which is what we do. We will likely not be a good professional. I'm trying to skip a lot of things so that we can pay attention to. So again, should I look at guidelines for selecting good outcome measures? We all know all this. What I can just say is that whatever outcome measures, again, we use, let's use it within the ICF. The ICF is very important for us to use in our practice, irrespective of our professional leaning. Every outcome measure works within the 3 levels of the ICF. Every outcome measure works within the 3 levels. There is no outcome measure that is applicable at all the levels. So this is one way of actually detecting when a specific research has been doctored. Like an outcome measure is applied at body structure and function. And I'm reading the article and they're giving a report on participation measures. There's no evidence anywhere that because I manage spasticity in patients, and I get result in participation activity of the patient. There's no evidence for that because body structure is focused on the impairment, on how to relax the muscle. It doesn't necessarily mean the patient participates in his daily activities, except I train him on the context of his daily activities to do specific practice, specific training to be able to do those things that matters to him daily. The fact that the patient gains muscle strength does not mean he's able to do those things that matters to him. A lot of us don't understand this context because most of the patients whom we treat already knows what they are doing before they had the problem. So they do their own thing and they try to do what they used to do. So we assume what we are doing is what works. Do it for children. Strengthen muscles of children with cerebral palsy, and you think they will use it to go and feed themselves. It won't work. If you don't train feeding, they are not going to learn it. There are many children with cerebral palsy with muscle power 5 that is not functional in doing any daily task. So how can somebody now tell me muscle power is the reason why you perform task? Muscle strengthening does not lead to neuroplasticity. Only skill training leads to neuroplasticity. Again, the fact that a patient can walk around doesn't mean he's participating. A patient might be able to move around. Yes, he's so conscious of himself socially that he doesn't want to go to church because of his impairment. He doesn't want to go to mosque because of his impairment. So how will I now say, because I manage impairment, he's able to do participatory activity, it improves his quality of life? When, since he had a problem, he refused to go to mosque or he refused to go to church. His daughter want to have wedding, he refused to go to be the father of the bride because of his impairment. And I said, I've improved his quality of life because I manage his impairment. So you see outcome measuring impairment, and they are giving report on quality of life. The quality of life of a patient who refused to go and participate in participatory activities, who refused to engage in community activities again, because you measure impairment. It doesn't work like that. There's no evidence for that. So every outcome measure works at every IC, every levels. I think I should round up so that I can have something to eat. Again, I'm not going to talk about this. People like I will give us lecture on that one. Even while dreaming in his sleep, he will give lectures on reliability, validity, and all that. I think I just put all this there. In fact, I did it tonight, so I'm not going to. I just have to put it there so that I won't be accused that you just presented 4 or 5 slides. Don't mind me. So if we look at it, basically, then why outcome measure form the basis for production of all evidence? Let's try to apply them within the context of overall system so that we can improve our system. When we learn to improve our system, we can create more opportunities. We can create more services. If we don't use our outcomes and we don't look at issues from a global perspective of the LS system, we will not develop more services for the system. We can use our outcome measures and develop other services that physiotherapists or OTs and P&O can work inside the system. We can use our outcome measures and detect some things, and we decide that we have such a huge volume of patients with this kind of problem. Can we train somebody who will be able to handle this clinic to solve this problem? Because we detect it and we are looking at it from a global perspective, not just from that truth alone. We'll be able to develop further service. Then we provide evidence that there is need for that service. So evidence-based practice does not necessarily mean just in use of that evidence. Evidence-based practice also means ability to develop services for groups of patients that need those services. Because through your accumulation of data, you will see lapses, gaps in what you are doing and what needs to be covered as well. That you can only do that when you are looking at a global, not from the narrow perspective of just the two. I'm going to write up now. So, expert opinion, length of practice is not enough. You can have somebody who has been practicing for years, doing exactly the same thing over and over again. Let's generate evidence. It is important, and let's specialize because it gives us more depth. Through our specialization process, we're able to go more detailed, develop more services. We can develop as advanced practitioner inside the specific specialty. And we can develop activity to do a range of other activities within our specialty. Let's practice on the evidence. Self-appraisal and depth is key if we're going to practice on the evidence. In what aspect can I improve? What other things can I do? We must be a reflective practitioner where we reflect on our work and also be reflexive, able to take decisions even when information is not enough. There is always a context, again, apart from context of policies and practice. And when it comes to training, we talk about the clinical practice evaluation lags behind research. So we don't evaluate clinical practice, we evaluate the research. But there are others who argue that research tools can be used to appraise clinical effectiveness. So the tool itself can be evidence of your own effectiveness. How effective you are, we can use the same tool. The same tool that we have used to measure can be used to gauge your effectiveness. For instance, if a particular approach, let's say McKenzie for back pain, in this kind of case, within 5 therapy sessions, based on this case, as you have 5 therapy sessions, as you produce a result, and the patient is coming for 3 months. If based on experts, that if you know this is what you should get, and you are still treating the same patient for 3 months, it's a measure of your effectiveness. Because the pain of the patient is not reducing. It's still maintained the same way. So we need to drive for health outcomes, measuring health outcomes. It will help us in maintaining quality, effectiveness, decide our patients' choices, get informed consent. It will help us to take patients as partners. It will also help us to use our tools for economic benefit, so that you don't just put a price because I'm an expert in cerebral palsy. This is my price. So I want to charge 30,000 per visit for cerebral palsy case. You should be able to justify it. If I have to use this approach, this is what I have to do. If these tools give this is what I have to do. Rather than this is the standard, this is the benchmark. It's not productive. It's not productive. There are some children that even in 40 minutes, you are still with them. If they don't improve, they will not, you yourself, they will make sure that you decline. There are children that you are managing as a pediatrics therapist. Even if you call yourself general, they will turn you to recruit. So a patient that will turn me to recruit, and I need to up my game, they shouldn't pay the same price of the one that I know and will be able to get good result early, simple. It's not the same thing. So I need to balance it out. Economically, we need to use our outcome measures to look at the resources and use it wisely. Let's use our outcome measures for value for money, for economic purpose, time, the effort we put in. Let's use our outcome measures not just to measure the pace, but also to gauge our own productivity. How long can I do this? And our effectiveness and efficiency. And lastly, patient-centered, the quality of life of the patient. And finally, I will say this. Some of the things that I'm talking about here, if I know what I know today, my practice would be better years ago. If I know what I know today, I will long in the business. I will have developed myself better and showed a new direction to my life. Because sometimes we spend so much time doing things that we don't have the opportunity because of where we are working to reflect on ourselves until it is too late. And by that time, we might not even have that opportunity to take steps back because we've wasted so much time on things that we should not have wasted our time on. Like I said earlier, we can be very hardworking and yet still not productive for ourselves and for the patient. I don't know how one, like I said, I've been very hardworking, but am I productive for myself? No. Am I happy that I'm not productive for myself? I'm not happy. I wouldn't want any of you young ones here to fall into that. Don't. No matter how hardworking you are, be productive for yourself also as much as you are productive for your system. It's important. Thank you, everyone. Thank you.
Thank you, sir.
Yeah. Questions? Chief Mrs. Ari, how are you? It's been a while.
Fine, sir. Good evening, sir.
Good evening, my sister. I was in Port Harcourt 2 weeks ago. I didn't see any one of you actually. We came for something else.
Okay.
No problem. We'll still come back.
All right, sir. Thank you so much for very insightful presentation and insightful. Thank you.
Thank you, ma'am.
Hello, please, can anyone hear me? Hello? Please, can I be heard? All right. Okay.
Yes, we can hear you.
I was saying that we can take questions now. And of course, welcome comments too. So if you have questions or comments, please indicate by raising your hand.
In the absence of questions, I will repeat. Use your outcome measure to measure yourself also. There is a saying that the healer heal thyself. Measure yourself also. Make sure.
Thank you, sir, for the advice.
Make sure as you are improving lives, your whole life did not decline. I've also experienced, because when I traveled, I don't want to mention the state, there's a particular guy that the head of the department was telling me, because I mean, he has attended some of my workshops that said he's very hardworking, he's very hardworking, he's very hardworking. And I realized almost everybody is dumping their work for him because he's hardworking. And I was asking myself, I didn't say anything to him because I don't want to discourage him. If he's here today listening to my lecture, this is the forum to say something, because I don't want to go to their department and seem to incite him. But I pitied him because I don't know how long he's going to keep it up, to being so hardworking. And almost everybody's avoiding the job that he's ready to take up, and nobody's cautioning. I have done that as a young therapist, so I know what it means. I don't pray that anyone will go through what I went through, please. I have done that. I have done that, so I know. Use your measures to also guide yourself. How many patients have I seen? How many have I been effective with? Maybe you are being forced to treat up to 10 patients in a day, but you know in your mind, maybe the first 2 you are effective. The remaining, you just rub their body and tell them to go. Somebody just said patient decline other therapies. Why are the patient declining other therapies? Because they believe you are more effective. However, while all the patient loves you, they also love you to the detriment of yourself. They love you, you are excited, they will call you, they want to see only you, but you are dying. But there are others there. That is why there must be a benchmark where everybody does his own duty. You are not a slave driver. I'm sorry that I'm talking this way. I'm sorry. I'm sorry. I'm sorry. I hope none of you is angry with me. Be good to yourself also. Use your outcome measures for your own benefit. Evaluate yourself every time. Evaluate yourself every time. It's not only about the tool, the system, your home practice as well. Thank you, everyone.
Thank you very much, sir, especially for
Thank
this
you,
last.
sir.
Thank you so much, sir.
Hello, sir. I didn't hear what you said.
I said thank you very much, sir, especially for this last piece of advice, sir. Thank you very much.
You're welcome, sir. I'm happy that you appreciate it. Thank you. Thank you. So, can I say, Chidera, can you round up? Okay, somebody. Okay. Aisha. Okay, oh, no, Dr. David. Okay, go ahead. Go ahead, man.
Okay, good evening, sir.
Good evening, man.
I will speak after the speaker.
Okay.
Okay. Sir, for the advice, please, sir, don't be sorry. I love it too. You are enlightening us and you are giving us a very candid advice. I didn't expect you to stop it. Please, sir, if you have more, tell us. Thank you, sir.
Thank you, man. Thank you for appreciating. Thank you. Thank you too. Thank you. Dr. Rigbe, please go ahead, man.
Good evening, sir.
Good evening, man.
Okay, it's been some days. Now, I want to really appreciate you for this lecture, sir. It's something that we all need in our training. And then the very last piece of advice.
What's that? That breathing, man. You scared me. Oh.
I didn't scare you.
You know when you say,
Yeah.
okay, let me put it this way.
A situation where it looks as if because of one's level of practice, every patient want to see like, it is you I want to see.
Okay.
And then it looks as if you want to say no,
Right.
you're like, patients are like being denied.
Right.
And the system itself does
Right.
not even think of developing you or
Right.
giving you a breathing space.
Right.
What can one do? That's question one. Then the
Madam,
second question,
let me answer it one by
I
one.
have two questions for you.
Okay, ma'am.
The second question, on the use of outcome measures,
Yes, ma'am.
I know we've discussed this before, which is when there's no uniformity of guidelines or things that one do. Where you think these outcome measure, let's take pain for example.
Right.
There are different outcome measures.
Right.
I believe that we still need to have our own practice guideline.
Yes, ma'am.
There are countries that have their own guidelines that, I mean, they know that when it is this condition, this is what you use.
Yes, ma'am.
But we don't have any. We
Right.
might have, it might do us a lot of good if we start having but people that come together to work on guidelines for us. Even if we are adapting, so that if I decide to use a guideline, anybody that pick that patient up next understands why we are all using that kind of guideline. So we still have a lot of work to do, and it is you, the elders, that will help us to raise something like this here on how we can have guidelines on outcome measures, on treatments, guidelines, and things like that. Because there are some people that don't even see the need why some people should use outcome measures. You are wasting time. There are many patients sitting outside. And if we don't use outcome measures, we will not know how effective what we hold in our hand
Right.
as treatment are. So how can we break through on this
Right.
matter? Thank you, sir.
Yes, ma'am. Let me first go to the first question. I will say it, and I'm saying it openly to all therapists here. A lot of us have no value for ourselves. I myself inclusive, because, like I said, I've done some things in the past that as years goes by, I realize that being hardworking have not made me that much productive for myself or effective for myself. And I need to balance. So as a professional, you must be able to grow in your practice and in your personal life. If your practice grows and your personal life is declining, then try to have a balance in there. One day you are going to leave government. However, even if you have not left government, what about if the job leaves you? You get to a point in which you are burnt out and you just can't keep up to the tempo at which you are working, and you have no time to even recover yourself. Often, by the time we burn out, we have burned ourselves out at the point or at the level or age at which we are no longer productive again. That's when we realize we are burnt out. That's when we realize that we have worked so much, doing so many things, and we have not paid attention to ourselves. Which happens to me. Hello? Right?
Yes, I can hear
Now,
you. I can hear you.
when it
I can
comes
hear
to
you, sir.
patient wants to see you. Every patient request for you is wonderful. We all like it. The patient loves us. But always remember again that those patients, no matter what, needs to have effectiveness, because a patient that likes you recommends you to another patient, recommends you to another patient. What you don't see coming is that all these patients also have people whom they are talking to. They might like you because of the attention you give them. That doesn't mean they value you. You don't know what comments they are passing behind your back. So you can have a system where a lot of patients comes in and patients keep coming, either because they felt they are getting their way and it's easy for them to get their way, not because they value that system. The day you put in order for things to work well, many of them might go away because you want to make things work well. So you need to first reflect. Why do they want to see me? Why are they rushing? Is there something that I'm doing that is giving them that room? Because if you are actually making yourself that cheap that people rush you, they will want you out. At the end of the day, don't be surprised. When they need private person, they might still not call you. They will call somebody else. But they use you, they value you because of the value you put on yourself. Secondly, every patient you see in the clinic, I refer by a medical doctor or know someone, the comment they pass about you is about the value they put on you, not the attention you have given them. It's about the value. So a lot of time, we devalue ourselves by making our services so cheap, not only in terms of cheapness, in such that we don't even put in any order into our system, either because of some seniors who know so many people in the management and who allows anybody, every day can hurry to just come. Cheap is good. We can sit down in our meetings and be talking about how our practice can be better. However, the whole of the hospital system devalue us because there's no orderliness in what we do and the value we put on ourselves. We work ourselves to the point that we are almost like a slave. We don't even have time to be effective. So 10 patients come to you, Dr. David, you know these 10 patients wanted to see you, but you know after you see 3, the remaining 7, you are no longer effective. There is no reason to keep yourself working at that stage because you yourself, you know your productivity has declined. Before you start addressing your own health, you will lose everything. You will have worn yourself out because you are not measuring yourself to what you are doing. Even without using those outcome measures, you know you have 10 patients. The first one I treat very well. The second one I treat very well. The third one I treat very well. By the time it comes to 4th, I just want to quickly finish. From 4th to the 10th, none of them receive good therapy from you. The comment they will pass off you is exactly how they felt about you at that point. But what is important there is, am I being fair to myself as well? I must grow. I must grow. While I'm measuring patients' outcome, let me use the same outcome to measure myself outcome. At what point have I treated patients that I felt burnt out? Maybe we all now need to sit down inside our offices and talk it out. After this, I get burnt out. The rest, I'm not being effective. Something has to be done. Either there is more staff recruited, but something has to be done. 2, let me say this politically. for every patient that we are not giving professional service to. We are giving room for non-professional to look at our work as being nothing because we are not applying professionalism to our work. When our work becomes rudimentary, so also people start looking at us as being rudimentary because they are not seeing anything in what we are doing. They are not seeing anything in the offers we are giving to those patients anymore because it has become a rudimentary thing. It's everything same way, same thing, same day, in and out. With this process, we ourselves, we do not have that opportunity to develop ourselves, to develop our skill, to even be better because we are overwhelmed. The reality at the end of the day, quit the system, somebody will do the work. The patient that hails you today will say something about you, something else about you. And in my own experience also, the patient whom you work hard to help most, they are the one who give you problem most. They are the one who give you problem most. The patient whom you struggle to please, they are likely going to be the one who pass disparaging comments about you the day you fall short of their expectation. The key thing is that we measure for patients, we measure for the system. Let's measure for ourselves also. We should not. That is why our home professional practice, that is why we need depth. We must reflect where I have improved, what makes me improve. What about me? What about myself? You need to self-reflect every time with your practice. Reflect, reflect. Inability to reflect is bad. Inability to reflect is bad. Now, to the last, that one, again, a lot of us who are seniors are the problem. A lot of us who are seniors are the problem, Dr. Arebe, and I'm telling you, a lot of seniors are slave drivers. We sell our juniors very cheap. We work through this system in a way that we don't even expect them to develop reasoning to whatever they are doing. We just want them to follow what we ask them to do without them reflecting. So if I have somebody, Aisha is working under me and I work under someone for 15 years who did not allow me to think or reflect. I must do everything exactly the way it's done. I'm going to train Aisha to work with me also, not thinking. So we set up a system that kills the system. We set up a system of grooming ourselves as oxymorons, as professionals. We don't think, we don't reflect. Because that is the way I used to do it. That's the way I was taught. You must continue. Even though we claim we are using evidence-based practice. So, outcome measures is important for patients. Let's put everything within the context of measuring health outcomes. And when we do that, we are not only reflecting on our patient, we are also reflecting on ourselves as well, politically, economically, and all that. And let's be fair to ourselves. So that as we grow professionally, let's also grow personally. Don't grow profession without growing yourself. Make sure you don't decline. Always bring yourself up so that at the end of the day, you'll be fulfilled. Through that fulfillment, people will be encouraged to want to be like you. Thank you, everyone. Good night.
Thank you very much, sir. Good night.
Good night, sir. Good night, sir. God bless you. Thank you, sir.
Can we hold on? Hello, good evening. Oh, please, can we hold on?
Okay.
Thank you so much, sir. It was more than wonderful. All right, so if there are no more questions or comments, ending the meeting at this point, and then I'm going to be dropping the link for our quiz right away, and I will encourage us to get the quiz done immediately, to be on at least for like 30 minutes to 1 hour. I don't know if I'm heard. Suddenly I lost my voice this night, so it's been really difficult.
Yeah, we can hear you. No problem. We can hear
All
you.
right, thank you. So I'll be sending the link right now, and I'll encourage us to do it right away. Thank you.
Yeah. You hear me? Your voice will come back.
Yes,
It's very
definitely.
hot. Yeah?
Yes,
She
sir.
said definitely. As if she knows where they are selling pepper soup. I can tell you where they are selling good pepper soup. If it's dog you want, there's dog pepper soup, goat pepper soup, chicken pepper soup. Which one you want?
Thank you so much, sir. Thank you. I'll be fine.
You
Okay, all
like dog
right.
pepper soup? It's not
No,
in your
sir.
house. So. Good night.
Okay, all right. Thank you so much, sir. This point is going to be a good night. Good night, everyone.
Good night, sir.